Good evening. Welcome. I'm Dost Öngür. I think today's third presentation, everybody knows me anymore. The people who came to hall now already saw me. With dear Ali Safet Gönül, we will be speaking on the use of neuroimaging studies from clinical perspective. First, we had Ali Safet, but towards the end of this program, I have to go to another place as a part of my task. So he answered me, he allowed me to take the first place, so I start my presentation. The first slide is apparently lost. Okay, then let's start from here. How can neuroimaging contribute to clinical psychology? We will be speaking about criteria, what have been done so far. I like to start with this slide, fluoroxyl glucose path. It's studying the glucose mechanism in brain. It has been published in 80s. It's older than 30 years old. Mid-age patient is hospitalized for depression, and he participates in a depression research study, and the top brain views has been taken. These are axial. This is the top part, this is the medium, this is the bottom part. The cool, warmer color shows higher glucose levels. After these antidepressants have been started, and patients enters into hypomanic, either manic patient, and then they wanted to take another imaging during the manic phase, and they repeat the same imaging with 3 weeks interval. Then they started lithium, and 3 weeks later patient goes back to depression, and they take again the imaging image, and they find the same patient, the same technique, 3 images in 6 weeks, and they have dramatical differences. You don't need to make a statistical analysis to understand there is a problem here. Apparently, while brain is passing from one phase to other phase, there might be very serious differences. This is belonging to one patient under very special circumstances, and it's a really knowledgeful patient. If this would be like this, of course, we would have used neuroimaging technique is so good, so widely in psychiatry. We are not using it so much because we don't have findings a lot in this. I didn't put here for asserting that glucose mechanism is very important in brain and it makes the difference between mania and depression. But if you keep this in mind, maybe you will one day be remembering it related to psychiatry's neuroimaging. There is a great excitement here in America and in other places discussed a lot. American Psychiatric Association, APA, founded a working group here. A few years ago, they wrote a consensus report, Neuroimaging Markers of Psychiatric Disorders. Why this is being discussed, as I said, for diagnosis and prognosis, can we use it as a test? You will have a patient, you will tell the patient, okay, clinically you say that you are depressed, but let's make some tests and let's see what's the real situation, and later on we can select the treatment. Can this be possible? Especially the drug companies which are developing new drugs, they are really interested in this. Instead of showing the clinical endpoint, they can show differences in brain, and it would be easier to develop drugs, and they can use EMR works, MRI works in a much better way. So it's not just an academic interest, but also a clinical interest, but also a commercial interest. You see in the first paragraph, it's described as a revolution using neuroimaging in psychiatry. What do we need to use it as a biomarker, the neuroimaging? There should be at least 2 independent studies, and sensitivity and specificity of these studies should be 90%, 80%. At the moment, there is not a recording, so we are not translating at the moment, but it will continue if it's needed. I took this paragraph from schizophrenia, and in the backdrop of this study, there is such a point related to MRI. This is especially valid for diagnosis, especially for diagnosing. And one of the problems for diagnosing is making a differentiation between healthy and unhealthy individuals. But it's hard to differentiate two patients from each other. And what we need for disease is this. That's why we cannot go forward in MRI. Why? What's the challenge? Why it's like this? The phenotype doesn't mean that it's a mild patient. We are working with very severe patients. If you are interviewing a patient for 60 seconds, you have to distinguish between healthy and schizophrenic patient. You need you can select with 100% sensitivity or specificity, but the brain abnormalities are not like this. Many diseases can cause similar results: depression, anxiety disorders, bipolar. Another one is missing in the slides. There is a wide overlap between schizophrenia and bipolar, or also depression and anxiety. But how we can cope with these overlappings, how we can see truth. For example, there is a study, it's in Munich. You see here, between depression and schizophrenia, in acute and lifetime, there are comparisons, many comparisons, sensitivity, specificity, positivity, all the figures are measured. This is structural MRI based. By looking, they are thinking if we can group it by only looking at the structures of brain. And unfortunately, positive predictivity, we don't have many studies which are higher than 80% for both of the values. There are only one or more FIF, and most of them are not repeated or replicated. But also you can say that still there is some exciting findings from the same article. These are the findings. The blues and reds. The blues have a higher in schizophrenia, in the red ones. The other one is bigger. It's just like a shotman appearance. They just shot with a rifle, and we have a lot of holes in the wall. It's impossible to understand. Rather than a pattern, it's apparently an abnormality throughout the brain. For example, in cerebellum, schizophrenia is bigger. Prefrontal or cortex depression is apparently bigger or wider, but reliably we cannot just believe in it. I wish we had something like this. In striatum, we know that schizophrenia is important, and these findings are in striatum, so it's schizophrenic. And we know that depression is important in orbital cortex. I wish the case was like this, but unfortunately not like this. But we don't have it. This study, Orhan Demirci, electrical engineer, working with NIFSCOM group in New Mexico, they did something similar. The question asked here, if I take images from a group of schizophrenic patients and a group of healthy individuals, and if I compare them, and if I look at the networks, this is MRI, this is the top part, medium part, and bottom part. These are axial cuts parallel to ground. After they collected these images, by looking at the patterns of brain activity, if I measure the connections of the various parts of the brain, it's possible to do this sort of analysis, and it became more and more widespread. For example, we see that the right and left part of the motor cortex is related. Frontal and temporal lobes are connected. Visual cortex is obsidial point. It's just isolated and independent. So we can define a few networks like this. Having defined networks like this, it's possible to see the differences in patients and controls. This is what Demirci did. after defining various networks and measure the figures goes from 75 to 80 to 90, but it never becomes 100%. The performance of these measurements, even if you enter too much, too detailed data, it begins to go bad, worsen again. Kutuder's works, it was structural MRI based. Here, the functional MRI had been used. The connections in various parts of brain had been brought together, and success ratio doesn't approach to 100%, always below 90%. If we cannot put forward very clearly the differences among diagnoses, can we say something about the long-term evolution of psychiatric diseases? This is a Netherlands-oriented study, ultra-high-risk patients, not psychotic, but they might have psychosis. Not patients, but individuals. Mostly individuals with psychotic diseases, and they have some deterioration in their symptoms. Maybe they are displaying prodrome symptoms. Their MRIs have been taken, clinically followed, and MRIs are repeated. And they ask the question whether they know who will become ill, for example, 3 years later. The baseline, and to compare with, by comparing these MRIs with 3 years after MRIs, can we find this? It's a very important question. If we can do this with MRI, when a patient came to the doctor's office, I am suspicious about this, but let me do a test and I can give you a better information. No, we cannot say that. It's not so easy. In this study also we have similar findings. When we looked at the volumes and structure of various brain regions, sensitivity, specificity is around 50, 60, 80%. Unfortunately, it's hard to find a predictive value here. But still they try to do something by bringing together all the brain regions, by bringing about the volumes of brains, and they are building a statistical model. And they can predict the GAF, General Assessment of Function score. And the GAFs can be predicted, even if they cannot know who will become psychotic. But if there is an individual who has problems in the school, not happy from his life, and differences with a normal-going young person can be predicted over brain structure, but it's not a very strong statistics. You see it here, but still there is a great scattering, but GAFs, the models coming from GAFs are low, and if it's higher in the reality, it's also higher in GAF scores. It's possible to get some clues from brain data. This is a single study. Sample is not bad, but it's a medium-sized study. We cannot take it into too seriously. But departing from brain data, it's possible to get some insights related to the functionality of the individual. But if we are asking for a clinical test, it's not easy to do this. We are also interested in this sort of studies. This is one of the studies which we have done. What we wanted to do here is, if we are challenged in prognosis or diagnosis, can we understand it from symptom? Instead of studying schizophrenia or possibly schizophrenic individual in the future, maybe we can compare the existing and non-existent symptoms so as to understand better the cerebral mechanisms. In this study, they are all schizophrenic, but some of them are having auditory hallucinations, and some of them do not have it. And we tried to create more or less balanced groups, age, clinical factors, gender, function. We tried to set up equivalent groups, and then we looked at the connections in brain, especially in primary auditory cortex A1, the first auditory cortex. And we looked at its relations with other sites, and we found that hallucinators had more parietal and frontal cortex, and the non-hallucinators had stronger connections with the hypothalamus. Interesting, but when we have done these analyses, if we took MRI from any patient, and after, if we ask if does he hearing auditory hallucination, we looked actually, but we didn't find it in the paper, and our sensitivity or specificity unfortunately cannot go over 80%, not very strong. Why I'm telling this? Yeah, it's nice to research on schizophrenia, but schizophrenia itself is something very heterogeneous. And a patient who I diagnosed as schizophrenic and you diagnosed as schizophrenic, are they the same people or more or less the similar people? Rather than focusing on here, maybe we can focus on making more healthy classifications, and hallucination could be one of them, we thought, but we couldn't improve the performance. Another example from bipolar disorder. In this study, they tried to differentiate bipolar and major depression disorder, MDD, clinically very important. You know, a patient entered the clinic if she is in a depressive situation. It's not a detail if this is major depression or bipolar depression. This is something which will dictate the therapy, so it's very important for psychiatrists. I have an idea, let's make a test and let me see the results, and then I will give a better decision. I wish we could say this, but to say this we need to see the differences between bipolar depression and MDD. During a test, emotional regulation test, healthy controls are in this frontal region of middle frontal gyrus. In healthy control, there is a bit deactivation. In depressive, major depressive patients, there is a serious activation. In negative activation, deactivation, and in bipolars, there is an activation. So it's possible to reveal the differences among three groups. Depressive patients are actually using a strategy used by healthy individuals, but more intensively during emotional regulation, and bipolar patients are using a reverse strategy. Interesting. But what we will be having in the long run, we don't know. There is a great interest in this for differentiating bipolar and MDD with regards to neuroimaging, cerebral imaging. This might be one of the most important contributions of brain imaging or neuroimaging into our sphere, our field. But a great majority of these findings cannot be replicated. When the others repeat it, they cannot find the same things. Even if they find, it's not so strong. It's not as strong as to make it into a test. A similar analysis, as I said, there's a great interest here. The relationship between amygdala and other regions are looked in bipolar depression, repressive patients and remission patients. This is the connection of amygdala with frontal regions. This is correlative cross sections. These are eyes. This is the skull base, and this is the skull roof, skull top. And in healthy individuals, they are looking happy and unhappy faces. And while looking this in the connection of prefrontal cortex with amygdala, the healthy individuals are using these regions more when in comparison to remission bipolar. And with depressive bipolar, it's more, especially while looking happy faces. When we compare two groups of bipolars, while looking to happy faces, the remission patients are stronger. When looking at unhappy faces, the depressive patients are more stronger. How prefrontal cortex is modulating amygdala, this can be thought, but we cannot just reverse it, and after taking an image, and if you try to decide if this patient is in depression or in remission, you cannot find the answer. This is a paper, the first author is Ayşe among us. Ayşe's question is what we can do related to clinically relevant neuroimaging studies. In schizophrenia, many different modalities are being used, and by using these modalities, many studies have been done. Also, neuroimaging studies have been done. Before initiating treatment, in baseline, the MRI had been taken. After this, antidepressant, CBT, or ECT, or RTMS had been started. Many different things had been done. And then any MRI had been taken. It's a great literature, actually. We have read dozens, or actually Ayşe has read dozens of papers. When we brought together all these papers and created tables, we saw that generally this schizophrenia therapies causes differences in frontal brain regions. But it's a literature consisting of many inconsistencies, and if the patients will go better, this part of brain will be suppressed in this way or activated in this way. We couldn't find this. We just said something very general. The frontal brain region, dorsal lateral, medial prefrontal cortex, arterial sigmoid, even premotor areas had exhibited some findings. It's covering a great area of brain functional differences, covering a great area of the brain. Despite all these, still they are speaking about the end of the 30 years of solitude. Neuroimaging biomarkers will be used for predicting treatment response in schizophrenia. It's not easy. It's not easy. It's the prospect. It's a hope. In today's studies, some reasonable things can be found. Generally speaking, or statistically, they are not bad as findings, but no findings for using as clinical test. I wish they would be all strong, validated, and strong markers can be used in a single individual. You will make an imaging in a single individual, and you will predict the therapeutical response. Also, person stratification in clinical trials, or you have a new treatment. You don't know if it will be good for patients. You will take their MRI or other imaging according to the response. According to the result of the test, you will give or not give the treatment. I wish we had it, but unfortunately not. We don't have it. But there are clues about this. There is something interesting done. For example, this study, first attack in psychosis in hospitalized patients. Striatal functional connectivity MRI is taken, as striatum's connectivity with the remainder of the brain is being quantified. Then they begin to give antipsychotic to patient, I think 4 weeks after. After 4 weeks, they come back and replicate the MRI. The baseline MRI and what's the relationship between the baseline MRI and antipsychotic response. They do it in a few different groups, and really, striatums, if the striatum's connection with the other parts of the brain is negative, they respond to antipsychotic. But if there's a positive connection, then there is a non-responder. Patient with good mobilization, the patients who can build positive and negative relationship between various regions of brain, responses to the drug, and they repeat it in another group, and with the same pattern, they find the same things. So specificity, sensitivity is very promising. Maybe in the future, when we measure the relationship with striatum and periatum, we will be able to say that this patient will respond to antipsychotic. I think it was around age measurement over more than 20 patients, 20-some patients. Not very reliable, but a good start. When we speak about treatment response, this is one of my favorite studies from UK. Dopamine synthesis capacity in brain had been measured with fluora PET. When the fluora dopa PET, the radioactive dopa enters in brain, the more they make dopamine, the more dopa they take from blood circulation, and radioactive dopa stays in brain. There are 12 healthy individuals, 12 treatment refractory schizophrenia, and 12 treatments responding schizophrenia. The treatment refraction or resistance had been defined very seriously, the dose, the periods, the general condition of the situation. They didn't just say this is refractory, this is not. They stick to the criteria and results. In treatment-resistant patients, dopamine capacity is normal. In treatment-responding patients, there is too much dopamine. Well, I didn't find it reasonable when I saw it for the first time. So they are treated, they are treatment-resistant, they should be in worse conditions. Then I read the study and it convinced me. The comment is like this. What's treatment? Antipsychotic medicines, dopamine medicines. So if there is a problem in your brain related to dopamine, and if I give you a dopamine drug, it's good for you. But if there is not something related to dopamine in your brain and I give you dopamine, it doesn't work because you are resistant to treatment. Actually, treatment resistance is not something related to severity. It's not a process which we cannot cure. It's stemming from the insufficient or inadequate treatment. And the same group had been done with the glucomate, and a reverse pattern has been saying there is a problem in the treatment-resistant group, but there is no problem in treatment-responding group. Maybe schizophrenia, what we call schizophrenia, is more than one disorders. And many patients have dopamine when they are given antipsychotic. It's good for them, but some of them don't have glutamate, the GABA inhibitor receptor, etc. Everybody has a different hypothesis, and if this is like this, we can find very meaningful results. If you will diagnose a patient as schizophrenic, you have to make a test for dopamine, glutamate, or other things. You will act according to the results of the tests. How nice would it be? But of course, 12, 24 patients, still this is the dimension, the size of studies. This is one of our studies about treatment response. Glutamine-glutamate ratio is looked. This is related to the activation of neurons. The more activated are neurons, this ratio, the higher should go this ratio. These are bipolar 1 depressive patients, depression patients. They are already taking mood stabilizers, and we added Rizol. Rizol is used for ANS, having glutamatergic features. We gave Rizol and we measured glutamate, and in the baseline, these were the findings, around 3 point something, and at the end of study is more or less here, around 3. But there was something very interesting. In the second day of imaging, just when the drug was going into brain, we see such an increase, especially in acystinatin posterior regions. When the 6 weeks, this is reversed. Actively, brain is actively responding. But in the beginning, it's giving this, but after it's compensated, since system is pushed to a certain direction, the brain wants to go back to the beginning point, and meanwhile, the depressive symptoms are getting better. Arizol was really good for depressive symptoms, but if we haven't done the second day study, we haven't seen any change in 6th week, and we would have said that Rizol doesn't work good for brain glucomate, and we would have just continued. We should think good of the dynamic part of the brain, and we should be attentive about the dynamic features of brain. When we're speaking about neuroimaging, it's not like I took an image, I found or couldn't find anything. Maybe we will have to make dynamic imagings 1 week, 2 weeks, whatever. Maybe in this way we will see the clinical reactions. Related to biomarkers, there was a very prospective and hopeful paper. This is similar. Diagnostic and clinical implications of bipolar disorder. What can we learn from this? A very hope-giving paper. It says the encouraging, maybe eventual benefit, maybe in the future it will work for us. A paper full of hope, but still we haven't covered enough distance. One of the reasons for this is like this. A study which I have done maybe 10 years ago. I will not go into details. Glutamate ratio, the activation of neuron, it's more or less consistent in healthy individuals, in bipolar patients and schizophrenics. Why I showed this is when we look at the scatter plot, the lowest control is below 0.1 and highest control is 0.6 or 7. Same goes for sick people, 0.2, 0.3, and it goes to 0.8 or 0.9. These are the ratios of chemicals in brain, a very basic parameter actually, not so functional, so special. You look at the concentration of chemical and you see such difference. Of course, when you bring them together and show them a clear bargram, you think that all the patients are here, there's a great difference. But look at the overlap. This is the beginning and end of the healthy individuals. In bipolar, it's like this. And nearly all of the bipolars are actually having the same values with the healthy group. In the future, if I take this imaging and if the value is here, I cannot tell him to be bipolar because the healthy guys have this. But in the lowest part, there is a difference. But even here, the schizophrenia is here. You see how wide is range. This is the reality of neuroimaging. The individual data are so different from each other. There's a great scatter. When scatter is so big, it cannot be used in clinical environment. In order to use them in a clinical environment, you have to have a much consistent range. This is another study which we have done. It has been issued recently. NAD and ADH ratio is looked. We are looking at chemicals in brain. Maybe you would remember that these are biochemical cofactors. The cofactors used by cells but it's actually a redox ratio, oxidation reduction ratio. If it's high, it's healthy. It means that we don't have too much oxidative stress. But if it's low, it means that we have more oxidative stress. The red ones are healthy, the black ones are healthy, the red ones are schizophrenic. And there is a great age dependency. While the individual gets older, this healthy image changes. Here also we have a scatter. The highest and lowest healthy individuals are so different from each other. Same goes for patients. But sick people and and the healthy individuals are differentiated from each other. When you know the age and if you know the value, it means that you can find if this is a control or schizophrenic individual. These chemical data might be used in the future for more serious conclusions. I said that it's so easy to define a patient in 60 seconds, but for neuroimaging, you are paying billions of dollars, but it doesn't work, millions of dollars, and it doesn't work. It doesn't work. It's not correct to say that it doesn't work, but we don't have enough progress. We cannot just take psychopathology as an artifact and to look at it concretely. You just know what you observe and you just know what patients say. You will say that, okay, I will look at schizophrenia, I will understand the brain problems in schizophrenia. But what is schizophrenia? I did my best. I brought together a group of patients. I thought them to be schizophrenic. I measured them, 20% disorder. But if you are not sure that they are schizophrenic, you cannot also rely upon this 20% disorderly figure. I showed you some examples from various studies. It's very hard to know who these patients are, but it's highly likely that they weren't same patients. They were not schizophrenic in the same way. They weren't bipolar in the same way. There are even schizophrenic individuals who can work and sustain their daily life at least sustaining lives which are apparently normal from outside. Also, there are some people who cannot get out of their house. They are not same. When you measure their brain and take the average, it's not that meaningful actually. This morning during RDoC, I have shown it. The hope that will be given by neuroimaging, depression, dysthymia, and bipolar depression patients, we can differentiate them with DSM. But actually, they are not same. They are blues, greens, yellows, and reds. But maybe in one group we have more blue, and in another we have more yellow. But still, they are everywhere. And maybe they are not different. If we can bring them together, brain imaging, brain activity, or other biological measures, if we differentiate them as blues, yellows, greens, and reds, only then we can find real, significant, or relevant biological data. We will not have to say that it's according to DSM schizophrenic diagnosis. I took the imaging and I found these results. Instead of saying this, I will say that first I took an MRI, brain MRI, then I cerebral MRI, and I looked at the thickness and I classified them according to this.
RDoC'la da değil veya benim.
There is a lot of attention on the field, biotype idea, for example. This is an ongoing activity, that is research that is called Biological Schizophrenia and Neuroimaging Intermediate Phenotype Study. They are trying to measure the phenotypes in the brain. Schizophrenia, schizoaffective disorder, bipolar disorders, and there are also biotypes within them. Through MRI, through EEGs, through cognitive tests, they're measuring this. And maybe part of this schizophrenia are somewhat similar to the bipolars. For example, there are many bipolars here, only one schizophrenic, and there are many schizophrenia patients in the other one, whereas there are less bipolars. In some cases, some schizophrenics are much more similar to the bipolars, whereas some bipolars are much more different than the other ones. If we add the neuroimaging technologies, proper ones, we would be able to measure this. I'm going to make a couple of suggestions here. In the biologic measurements, there is a huge heterogeneity. Nosology problem and pathophysiology problem are added on top of this. You cannot depend on the brain findings and pathologies. How can we proceed then? We need to pay attention to the episodic course, from where and to where the patient is going. You need to carry out more than one study on the patient during the remission, schizophrenia, exacerbation, in the hospital, acute symptomatic, when some of the symptoms are treated, the others are not. Lack of diagnostic stability over time is an issue. Diagnosis is changing. It may be because of the contradicting opinions of the clinicians, but what I'm trying to say is that for the same patient there is a changing landscape. If you have been following a patient for more than 1 year, then especially after the panic attacks, you can see a totally new picture for some of the patients. If we are capable of following the brain functions during the evolution of the patient, it will be better. Triggered environmental events or endogenously issue, without the need of any trigger. Some people are going into the episode, whereas some others are triggered endogenously. But once triggered, it becomes an episode, and they are most of the time relatively stereotyped features, and the end of the episodes may be a problem. Before the discovery of the drugs, it was on the agenda. Once the patient goes into the episode, it is possible for them to be treated, self-treated in time. So in the brain there are some compensating mechanisms. If we can understand this, how can a patient recover? We sometimes say that it's because of the drugs, but it is beyond the drugs. We should pay attention to the brain functions that make this compensation That's why we need longitudinal studies. We need to pay attention to the fact that the system is very complex. You shouldn't get too enthusiastic after a finding, because inside the brain there is a network that is dealing with the entire activity. So when there's a dysfunction in the brain, then there's a dysfunction in the network. You can use this as an index, but it does not work to say, for example, amygdala has a problem. Maybe we can produce some prediction models, but we need to use longitudinal studies. I'm ready to answer the questions now.